saying there's a woman undergoing thoracic surgery for lobectomy and she is receiving a regional anesthesia technique for pain control. So typically for thoracic surgery, the pain techniques that we have are putting in a thoracic epidural, or you can give nerve blocks like paravertebral nerve block or erector spiny nerve block. Okay, so these are the common ones. Out of this, the easiest to perform right now obviously is epidural, because a lot of people are comfortable putting in epidural. But again, along with the technical difficulty in putting a thoracic epidural, the other problems that you can have are hypotension because of the epidural, and post-op you may not use it because of that. So another very, very nice block has come, and that is the ultrasound guided erector spiny nerve block. So they are asking you, what is the primary mechanism by which this block works? Okay, now let's talk about the block first. So this is the erector spinae nerve block. What is erector spinae? As you all know, they are three muscles, a group of three muscles. I call it as sister-in-law muscles because it is spinalis, iliocostalis, and longissimus muscles. Okay. Now these muscles run parallel to the spine or the spinal cord, and they actually are typically present over your transverse processes. So if you see, this is the spinous process of the vertebra, and your transverse processes that are there, that is around 2 to 3 centimeter away from the spinous process or away from the midline. And on this is where your muscles, your erector spinae muscles are present. All right. Now, if you look in this picture over here, this is my spinous process of the vertebra. This is one transverse process. This is the other transverse process. And as you guys can see, this is the group of muscles surrounding it. This is the erector spinae muscle. All right. Now, over the erector spinae muscle, you also have other muscles. So as you go from deep to superficial, you will have your rhomboid muscle and you will have your trapezius muscle. Okay. So you have TRE going from outside to inside. That is from the skin towards the transverse process. If you go, you have the trapezius muscle. And then the next muscle that will come in is your rhomboid muscle. And the next muscle that will come in is your erector spinae group. And then the erector spinae touches your transverse process. Okay. So when you place your ultrasound, how do you place your ultrasound? You place your ultrasound parallel to the spine. So this is called as the parasagittal scan. Now in the parasagittal scan, as you can see, I'm placing the probe longitudinally. You use a high frequency linear transducer probe. That is a probe that you generally use for performing your IJV cannulation, okay, your central line insertion. And then you see three muscles. So very distinctly from outside to inside. Now this is out. So you see your trapezius, then you see your rhomboid muscle next, and then you see your erector spinae muscle. Just below the erector spinae muscle, you see a hyperechoic line. This is the transverse process of the vertebra. Okay. So this erector spinae plane block, where do you deposit your drug? So for erector spinae plane block, what I do is from outside to inside, I actually put my needle out of plane and I go and touch the transverse process. When I touch the transverse process, it is bony, so I will feel some hard resistance. Okay. Now what I will do is that I will inject around 20 ml of local anesthetic over here. If you're going to use erector spinae plane block for analgesia purposes, then we can give anywhere between 0.125 to 0.25% of bupivacaine. Or if you want to use ropivacaine, then we use 0.2% ropivacaine. Okay. And how many ml will we give? We will give 20 ml of this. Now remember, this is only a one-sided block. We are going to give erector spinae on, if you see in the picture over here, you're giving it on the left side. You can perform it on the right side also if you have something that requires midline pain relief. Okay. Now let's come to how we give the block. So you touch the transverse process over here, you deposit the 20 ml. This is called as the erector spinae plane. The minute you deposit the local anesthetic, you will see that the muscle gets lifted up. So there is a space created between the transverse process and the erector spinae muscle. So the entire drug will spread over here and you will see that the erector spinae plane is blocked. And this will cover at least 2 to 3 dermatomal levels. Okay, so suppose I want pain relief from T4, T5, T6. So I'll give 20 ml of the local anesthetic at T4 level and it will spread up to T6. Okay, so this is called as the erector spinae plane block. Now, what are its indications? Mainly for thoracic surgery, surgeries of the back, surgeries of the spine, and then if you have any superficial surgeries of the back, and sometimes even for mastectomies, they will ask you to give a erector spinae plane block. However, paravertebral block is much better for mastectomies. All right. So how does erector spinae plane block help in pain relief? So that is important for you guys to remember. So what happens is that where your erector spinae plane is, what are the nerve roots that are present over there? Okay. So typically the nerve roots that are present are, if you see in the picture over here, you have your spinal nerves that are coming out. Okay, from here your spinal nerve is coming out and it is giving ventral rami and dorsal rami. So these yellow ones that you can see, these are all your dorsal rami. Okay, and these dorsal rami, they actually supply the skin, subcutaneous tissue, and the paraspinal muscles and the periosteum of the spine. Okay, if you look at your ventral rami, okay, so your ventral rami are mainly present in the paravertebral space, and then they will go and they will supply the anterolateral chest wall. Okay, so what happens in case of erector spinae plane block? Because you're blocking over here in this area, you are mainly blocking the dorsal rami. So they are very, very good for surgeries of the back, or surgeries where you're taking the incision over the back. Second thing is, if any bone is involved, like any rib fracture or anything related to the vertebra, okay, so then again, your erector spinae plane block is very good. But when we talk about the ventral rami, these ventral rami also do get covered in erector spinae plane block. How? They say that suppose you're giving the drug over here in this area of erector spinae plane block, the drug will move not just towards the dorsal rami, but it will also move a little medially, and it will cover the paravertebral space, and it may also go into the epidural space. Okay, so if the drug is going to go into the paravertebral space, then it will block the ventral rami. As I told you, the ventral rami of the spinal nerves, they will supply your anterolateral chest wall. Okay, anterior and lateral chest wall. So that is also covered under erector spinae, and of course some amount also goes laterally and supplies the intercostal nerves also. So there may be some amount of pain relief in the intercostal area also. Not much, but there can be. All right. So if I draw from your drug is going to go to your dorsal rami, your drug is also going to go in the paravertebral space where it will cover your ventral rami, and this is medially, and your drug will also go laterally and it will cover your intercostal nerves. Okay, so these are all the nerve coverage of your erector spinae plane block. So what is the mechanism of action? So mechanism of action is by diffusion of local anesthetic into the paravertebral and into the epidural space. So you have local. Okay. Next question. A 48-year-old man with persistent occipital headache is scheduled to receive peripheral nerve block targeting the greater occipital nerve. Okay. When planning the block, which of the following anatomic sites most accurately identifies the injection point for this nerve? All right. So first of all, we need to know things about GONB. GONB is nothing but greater occipital nerve block. Now, when we talk about the occipital nerves, which are responsible for headaches, so these occipital nerves are mainly three of them. So you have your greater occipital nerve, you have your lesser occipital nerve, and then you have your third occipital nerve. Now, what we are bothered about is your greater occipital nerve and where is its location. First of all, what are its indications? So as per Nysora, we use it for headaches, use it for migraines, you use it for cluster headache, cervicogenic headache, postdural puncture headache, all different types of headaches. Okay. Question is asking, where will you block the greater occipital nerve? So you have to remember two main anatomical landmarks. So one anatomical landmark is your occipital protuberance, the most prominent part at the back of your head, that is your occipital protuberance. The second anatomical landmark is somewhere behind your ear, this prominent part, which is called as the mastoid process. So in between the occipital protuberance and the mastoid process, so you draw a line. When you draw a line and you mark a point 1/3 along this line and towards the occipital protuberance. Okay, this is where your greater occipital nerve block is given. Now, why is your greater occipital nerve block given over here? So let's have a look at the picture over here. So as you see, occipital protuberance will be somewhere over here, your mastoid will be somewhere over here, And if you draw a line joining the two, around at 1/3 of point of this line, you are finding your occipital nerve. Your occipital nerve is close to your occipital artery. So some people will actually palpate for the pulsations of the occipital artery and give the nerve block close to it. Okay. So this is where we give our greater occipital nerve block. So 1/3 the distance from occipital protuberance to the mastoid process. Okay. So I've also written down the technique over here for you guys. And some people say that if you do not know that you can't feel occipital protuberance mastoid process exactly 1/3 of the distance, what you can simply also do is that just mark the midline and then you go 2 to 3 centimeter away from the midline, or just palpate for the occipital artery and go slightly medial to the occipital artery. Okay, so if you don't want to do this of 1/3 distance, then you can do this two techniques. One is 2 to 3 centimeter lateral to the midline. Second is just palpate the occipital artery and go medial to it. And the third option is that you can just feel for the occipital protuberance. Okay. So this is the occipital protuberance. Go about 2 centimeter inferior and 2 centimeter lateral to it. Okay. So if I see occipital protuberance, I go 2 centimeter inferior and 2 centimeter lateral to it. So this is the point where I will block the greater occipital nerve. Amount of drug required is very less, 2 to 3 ml of local anesthetic. Typically, if you are performing it for headaches, so then you'll give a local anesthetic of about 0.25% bupivacaine. And along with that, you'll also give an anti-inflammatory like dexamethasone to the patient. So 4 mg or 8 mg of dexamethasone can be mixed with the drug. Okay, so that is what we use for GUNB. Okay. A 64-year-old man with long-standing trigeminal neuralgia, unresponsive to pharmacological treatment, has come for radiofrequency ablation of the trigeminal ganglion. So, you're going to destroy the trigeminal ganglion. What is the most likely sensory complication following this procedure? Okay. Now, remember, from the trigeminal ganglion, we get three nerves. What are these three nerves? We get V1 division, that is supplying the ophthalmic area. We get V2 division, that is supplying the maxillary area, and we get V3 division, which is supplying the mandibular area. So have a look at this picture over here. You can see that this is the distribution of the V1 or the ophthalmic nerve. This is the distribution of V2 or the maxillary nerve, and this is the distribution of V3 or the mandibular nerve. Okay. Now remember, V1 is having just sensory innervation. V2 is also having just sensory innervation. But when you look at V3, mandibular nerve, then you have sensory innervation, plus you have motor innervation to the muscles of mastication. That is the muscles which you use for chewing. All right. So we have V1, V2, and V3. Now they are asking you what is the most likely sensory complication following this procedure. Options are facial muscle paralysis, severe bradycardia, dysesthesia, and corneal anesthesia, and permanent anhidrosis of the face. So let's have a look at what are the main sensory and motor innervations of V1, V2, and V3. So your ophthalmic nerve will mainly supply your forehead, your scalp, your vertex. And if in your eye, we are saying ophthalmic. So in your eye, it supplies the upper eyelid, it supplies your conjunctiva and your cornea, and the tip of the nose. Okay. So if I'm going to be blocking the trigeminal ganglion, and in that I block the V1 nerve, then I am going to get corneal loss of sensation, and it can also be corneal anesthesia. That's what we call it, corneal anesthesia. The other word is dysesthesia. So dysesthesia is unpleasant sensation. So you can get something like burning sensation or tingling sensation, all those kind of things. Okay. So this, yes, is the correct answer, that blocking trigeminal ganglion will cause this. Okay. Now, when I block trigeminal ganglion, V2 will also get blocked. V2 will supply sensory area to the middle part of the face, that is to the cheek, to the upper lip, to the lower part of the eyelid, all the maxillary area. Okay. So you can also have loss of sensation in this area, in the maxillary zone, that is shown in the red zone in the picture. And last is V3 getting blocked. So V3, as you can see, you provide sensory to the area of the mandible, and you provide motor to the muscles of mastication. So your mastication or chewing will become weak So those muscles will become weak, but you will not have complete facial muscle paralysis like it is given over here. Bradycardia has nothing to do with trigeminal ganglion, and permanent anhidrosis of the face. This is more of a sympathetic feature. So this will not be affected in case of trigeminal ganglion block. Okay. So your answer is dysesthesia and corneal anesthesia. Okay. Then let's go to question number 4. A 40-year-old male is scheduled for elective orthopedic surgery of the shoulder to provide intra-op and post-op analgesia and ultrasound-guided interscalene nerve block using 15 ml of 0.25% bupivacaine is planned. What is the most frequently encountered side effect of this block? So we have discussed this in the regional anesthesia SSMCQs also. Now let's have a look at the interscalene groove and interscalene nerve block. So in the interscalene approach to brachial plexus block, we perform it in the middle of the neck. What you see is your anterior scalene muscle on the lateral side. Then you see your middle scalene muscle. Sorry, extremely sorry. You see the anterior scalene muscle on your medial side. And on the lateral side, you'll see your middle scalene muscle. Okay. Now, in between them, there is a groove called as the interscalene groove. And in this groove, you will see 3 nerve roots, C5, C6, which is sometimes split, and you will see C7. Okay. Now, along this is my target site of injection when I'm performing the interscalene brachial plexus block. The problem over here is that there is another nerve that is present right above the anterior scalene muscle. This nerve is called as the phrenic nerve. As we know, phrenic nerve supplies the diaphragm. It arises from C3, C4, C5. Now, over here, as they are mentioning in the question, they are giving 15 ml of the local anesthetic. That is a large amount of local anesthetic given. The block is performed exactly like shown in the image. Your needle is always coming from lateral to medial. And you typically give your drug, which is shown in the yellow dots in this interscalene groove covering the C5, C6, and C7 nerve roots. But if you give a large amount of drug that is more than 10 ml, then it can easily spread above the anterior scalene muscle and it can go and block the phrenic nerve. Now, if the phrenic nerve is blocked, you will get hemidiaphragmatic paralysis. That is, the diaphragm on that side will stop working. So patient will be able to use only the other side, contralateral diaphragm for respiration. If the patient has any lung related issues, then the other side diaphragm will not be able to completely compensate and he is going to have respiratory distress. Okay. So this is called as phrenic nerve blockade leading to hemidiaphragmatic paralysis. This is quite common in interscalene nerve block. This is why we have started using ultrasound guidance so that we give less amount of drug, just 10 ml of the drug, and we make sure that we go lateral to medial. We don't start medial to lateral because if you're going to go from the medial side, there are high chances you will block the phrenic nerve on your way. So these are 2-3 things that you need to keep in mind while giving this block. Okay, so this is the ultrasound picture that you can see. This is your anterior scalene muscle on the medial side, middle scalene muscle on the lateral side, and above the anterior scalene muscle, you can see a small hypoechoic structure that is your phrenic nerve, which we need to avoid. In between, you see the traffic signal sign in between the two scalene muscles, which is nothing but your brachial plexus.